Dear colleagues, welcome to this webinar on amino acid PET in brain tumor imaging. My name is Carl Joseph Langen and I'm the team leader of the brain tumor imaging group at the Institute of Neuroscience and Medicine of the Research Center Jülich and at the Clinic of Nuclear Medicine of the University Hospital in Aachen in Germany. For more than 2 decades, the focus of our research group has been on brain tumor imaging using amino acid PET and MRI, and it is my pleasure to share our experience with you. Before coming to my presentation, please note the following 2 statements. This slide shows an overview of this webinar on amino acid PET in brain tumors using the amino acid tracer fluoroethyltyrosine, in short FET. After a brief introduction to the topic of brain tumors, I will give some background information on the use of amino acid PET. Afterwards, I will present a number of cases for the most important applications of FET PET. That means at primary diagnosis of brain tumors, for the assessment of recurrent gliomas, the diagnostics of recurrent brain metastases, and finally therapy monitoring of brain tumors. Brain tumors arise with an incidence of 14 to 20 new cases per 100,000 persons per year, and among these, cerebral gliomas represent a fraction of approximately 30%. Other frequent tumor types are meningiomas and brain metastases, and the less frequent histological subtypes have a combined share of about 15%. In this webinar, I will focus mainly on cerebral gliomas, but I will also address imaging of brain metastases. Today, therapy of cerebral gliomas is based on 3 pillars, namely surgery, radiotherapy, and chemotherapy. Surgery has been improved in the last decades, for example by microsurgery or fluorescence-guided resection, radiotherapy by dedicated techniques like intensity-modulated radiotherapy, radiosurgery or seed implantation. For chemotherapy, frequently used drugs are temozolomide, bevacizumab or lomustine, and there are a number of other advanced treatment options like immunotherapy or targeted therapies, which can improve individual treatment strategy. Despite these intensive therapeutic efforts, the prognosis of most gliomas is still disappointing. For patients with glioblastoma, the mean survival time is around 15 months. For anaplastic astrocytoma grade 3, 22 months. For low-grade astrocytoma, 4 to 7 years, and for low-grade oligodendrogliomas, about 8 years. An exception is only the pilocytic astrocytoma occurring in children and young adults, which can be cured in 95% of the patients. These data are based on older WHO classifications. Today, molecular markers such as IDH mutation play a more important role for prognostication. The method of first choice for brain tumor diagnostics is MRI using T1 and T2 weighted sequences before and after injection of contrast medium, which provides anatomical images with an excellent spatial resolution of about 1 mm. X-ray computed tomography is considered in cases of emergency or when involvement of bony structures is important. Additional information on tumor perfusion can be obtained by both CT and MRI. MRI is complemented by functional methods like fMRI, diffusion-weighted imaging, and diffusion tensor imaging, while PET allows to image a wide range of metabolic parameters such as glucose metabolism, amino acid transport, proliferation, receptor density, drug concentration or hypoxia, but with a lower spatial resolution of 5 to 10 mm. Furthermore, magnetic resonance spectroscopic imaging or chemical shift imaging can provide additional information on physiological parameters and the concentration of different metabolites at a spatial resolution in the range of 1 centimeter. This webinar is focused on the role of amino acid PET in the diagnosis of brain tumors. The most widely used PET tracer in oncology is FDG. In the brain, however, there is high background radioactivity due to the high glucose consumption of the normal brain tissue. This makes a differentiation of tumor from normal brain difficult, as you can see from the image in the middle. In contrast, as shown on the right, uptake of radiolabeled amino acids in the normal brain is low, and brain tumors can be depicted with a high tumor-to-brain contrast. Therefore, amino acids offer considerable advantages in the diagnostic evaluation of brain tumors compared to FDG and have become the preferred tracers for brain tumor imaging in the last decades. A frequently asked question is whether the increased tracer accumulation of amino acids is caused by a disruption of the blood-brain barrier. The upper row shows a patient with MR abnormalities in the frontobasal brain, but no contrast enhancement. FET PET depicts a brain tumor in the right hemisphere, which cannot be delineated on MRI. This example demonstrates that the uptake of radiolabeled amino acids is independent of a disruption of the blood-brain barrier. On the other hand, a disruption of the blood-brain barrier per se, as shown in this ring-enhancing lesion caused by radionecrosis, does not lead to increased amino acid accumulation, so that treatment-related changes can be better differentiated from recurrent tumor compared with MRI. This slide shows the uptake mechanisms of different amino acid tracers. Uptake in the brain and in brain tumors is mainly based on specific transport via the large neutral amino acid transporter LAT1, which is expressed on both the luminal and the abluminal side of the blood-brain barrier. Besides LAT1, the different tracers have additional uptake mechanisms leading to minor differences in tumor imaging. For example, F-dopa is a precursor of dopamine and accumulates in the striatum. Therefore, F-dopa is also used for the diagnosis of Parkinson's disease. The preferred amino acid tracer in our institution is fluoroethyl L-tyrosine. FET has been developed at the research center in the 1990s, and an efficient radiosynthesis has been established in 1999 so that FET can be produced in large quantities. As already explained, uptake occurs mainly by specific transport via LAT1. F18 labeling with a half-life of 2 hours provides major logistical advantages compared with the short-lived carbon-11 labeled amino acid tracers such as C11 methionine. Today, FET is one of the most frequently used amino acid tracers for brain tumor imaging, with more than 20,000 investigations in Europe. The high clinical relevance of the method is also reflected by the number of referrals for FET PET in our department. In the last 10 years, there has been a significant increase of up to 800 examinations per year. The most frequent indication is the diagnosis of recurrent gliomas, followed by the differentiation of newly diagnosed unclear brain lesions, the diagnosis of recurrent brain metastases, and therapy monitoring. In the following, I would like to demonstrate the clinical use of FET PET in more detail, starting with its application at primary diagnosis of brain tumors. This patient was referred for FET PET to further investigate an unclear right temporal mass, showing no contrast enhancement on MRI. 20 years before, the patients had transcranial resection of a pituitary adenoma followed by radiotherapy. FET PET reveals high tracer uptake beyond abnormalities in the T2-weighted MRI, indicating metabolically active tumor tissue. Surgical resection revealed an astrocytoma WHO grade 3. The next case shows a very unusual finding. The patient presented with progressive gait disturbance and MRI showed bilateral periventricular abnormalities classified radiologically as leukoencephalopathy. FET PET shows high tracer uptake bilaterally, indicating a malignant tumor. Biopsy revealed an IDH wild-type glioblastoma. This patient was referred for FET PET to evaluate the metabolic activity of this astrocytoma in the right hemisphere. FET PET shows low tracer uptake in the tumor, indicating a favorable prognosis, but detects a distant lesion in the right occipital cortex with high FET uptake. Biopsy in this area yielded a glioblastoma, which was decisive for the further treatment of the patient. The last case in this series shows another very surprising result. The patient had a histologically confirmed astrocytoma grade 3 in the right hemisphere and was referred for FET PET for radiotherapy planning. In the upper parietal lobe of the right hemisphere, MRI shows no contrast enhancement and no major abnormality on the T2-weighted MRI. FET PET detects infiltrating tumor in this area. This case demonstrates impressively that amino acids like FET can cross the intact blood-brain barrier and depict tumor tissue, which shows no contrast enhancement on MRI, and in this case even no abnormality in T2-weighted MRI. The usefulness of FET PET for detecting tumor extent has been proven in several biopsy-controlled studies. The majority of studies have compared FET PET with conventional MRI, but 3 more recent studies have also included advanced MRI procedures. All studies confirm that FET PET is superior to conventional MRI to evaluate tumor extent of gliomas, which is useful for planning of biopsies, planning of surgery or radiation therapy. Initial results indicate that a combination of amino acid PET and advanced MRI methods can further improve tumor delineation. However, it is important to note that the uptake of FET and other amino acid tracers is not tumor-specific. Benign lesions are usually negative in FET PET, but in rare cases increased uptake has been reported. This slide shows some examples of pitfalls in FET PET showing false positive tracer uptake, for example in multiple sclerosis, in a brain abscess, in acute ischemia and in a case of epilepsy. These findings are rare and do not play a major role in clinical practice, but must be kept in mind. The most frequent indication for FET PET concerns the differentiation of tumor recurrence versus treatment-related changes in pretreated gliomas. Newly occurring contrast enhancement in MRI may reflect either tumor progression or treatment-related changes, and decision-making is frequently very difficult. This 30-year-old patient was operated in February 2013 for a glioblastoma in the right temporal lobe. She subsequently received radiation therapy with 6D Gray and concomitant chemotherapy with temozolomide. The MRI check in June 2013 revealed unclear findings. FET PET showed focal uptake at the dorsal rim of the resection cavity, indicating tumor recurrence, which was confirmed by surgery. This 70-year-old patient was operated in June 2013 for a glioblastoma in the frontal lobe. He then also received radiation therapy with 60 Gray and chemotherapy with temozolomide. The MRI check in March 2014 revealed unclear findings in the area of the right thalamus. The FET PET showed high tracer uptake in this area, indicating a distant tumor recurrence, which was confirmed by further follow-up. The patient received further radiotherapy on the distant tumor lesion. This 66-year-old patient was operated in July 2013 for a glioblastoma in the right parietal lobe. After radiotherapy and chemotherapy with temozolomide, the MRI check in April 2013 showed an unclear contrast-enhancing lesion in the right parietal brain. FET PET showed low tracer uptake in the lesion, indicating treatment-related changes, which was confirmed by surgery. This 78-year-old patient was operated for a glioblastoma of the left parietal lobe. She then also received radiation therapy with 60 Gray and chemotherapy with temozolomide. The MRI check 4 months later revealed a ring-shaped contrast enhancement, which was suspicious for a recurrence. FET PET, however, showed low tracer uptake, indicating post-therapeutic changes. This diagnosis was confirmed by further follow-up of the patient. Meanwhile, a number of studies have investigated the diagnostic accuracy of FET PET in the differentiation of tumor recurrences and post-therapeutic changes in cerebral gliomas. High accuracy was consistently reported in the range of 80 to 90%, which is clearly superior to conventional MRI. Another area of growing clinical importance for FET PET is the differentiation of tumor recurrence from therapy-related changes in patients with brain metastases. This patient was diagnosed with bronchial carcinoma in 2010. 5 years later, a brain metastasis was detected. The patient had additional surgery and received fractionated radiotherapy. 10 months later, a contrast-enhancing lesion was noted at the site of the previously treated brain metastases. FET PET showed high focal tracer uptake, indicating recurrent metastasis, which was confirmed by the histopathological result after surgery. This slide shows a similar case of a patient with a metastasis of a bronchial carcinoma in the right frontal brain. 18 months after gamma knife irradiation and radiosurgery, the MRI showed an unclear contrast-enhancing lesion at the previous tumor site. In this case, however, FET PET showed no tracer accumulation, indicating a radionecrosis, which was confirmed by further follow-up of the patient. The number of studies that examined the diagnostic accuracy of FET PET in the differentiation of tumor recurrences and post-therapeutic changes in patients with brain metastases is still limited, but similar to the findings with recurrent gliomas, high accuracy between 80 and 90% has been reported, which is again superior to conventional MRI. The last chapter of this webinar demonstrates some examples concerning the use of FET PET in therapy monitoring of brain tumors. This 31-year-old patient suffered from a recurrent anaplastic astrocytoma in the left parahippocampal region after previous brachytherapy and radiotherapy with concomitant and adjuvant chemotherapy with temozolomide. The upper row shows MRI and FET PET at baseline, and the lower row corresponding images 4 months later after 2 cycles of lomustine chemotherapy. Enlargement of contrast enhancement on the T1 weighted MRI and enlargement of the signal in the T2 weighted MRI suggests tumor progression, whereas FET PET indicates a reduction of metabolic activity and response to therapy, which was confirmed by further follow-up of the patient. The next example shows in the upper row MRI and FET PET scans of a patient with a glioblastoma before radiochemotherapy. The tumor shows high tracer uptake, which is reduced 4 weeks after completion of radiochemotherapy, as shown in the middle row. At this time, it is impossible to estimate tumor response on MRI. 4 months after completion of radiochemotherapy, MRI shows a ring-enhancing lesion suggesting tumor recurrence, whereas FET PET demonstrated response to therapy as confirmed by further follow-up. This example demonstrates again the limitations of conventional MRI to monitor the response of the tumor to radiochemotherapy. Another diagnostic challenge in treatment monitoring of brain tumors with MRI is the phenomenon of pseudoresponse, which often occurs during anti-angiogenic therapy with bevacizumab. Bevacizumab is a monoclonal antibody against vascular endothelial growth factor and is an effective therapeutic option in recurrent glioblastoma. Bevacizumab can rapidly decrease contrast enhancement in MRI after initiation of treatment, producing an apparently high response rate. In this example of a recurrent glioblastoma, contrast enhancement disappeared after 7 weeks of anti-angiogenic treatment, indicating a good therapy response. FET PET, however, demonstrates that the tumor shows progression, which was confirmed in the further follow-up after 16 weeks. Thus, MRI shows pseudo-response and FET PET detects failure of therapy 9 weeks earlier than MRI. This table shows a compilation of studies that have investigated the significance of FET PET in therapy monitoring. It is consistently reported that a decrease in tracer accumulation correlates with a response to therapy. The only exception is brachytherapy with iodine 125 seeds. In individual cases, an increase in FET accumulation was observed after 3 months, which was not associated with a worse outcome. Today, amino acid PET is recognized worldwide as an important diagnostic tool in brain tumor diagnostics. The Response Assessment in Neuro-Oncology Working Group, in short RANO, is an international effort to develop new standardized response criteria for clinical trials in brain tumors. This committee has recommended the additional use of amino acid PET for brain tumor management. This slide shows a list of RANO publications, including practice guidelines, the role of amino acid PET in brain metastases, and radiotherapy planning, and more recently also a guideline for amino acid PET in pediatric gliomas. And this brings me to the summary of my webinar. Amino acid PET is helpful at initial diagnosis to differentiate brain lesions, to guide biopsy, especially non-enhancing gliomas, and to determine the extent of cerebral gliomas for therapy planning. The method has higher accuracy than MRI in differentiating tumor progression from treatment-related changes in recurrent cerebral gliomas and in recurrent brain metastases. Amino acid PET is more sensitive than MRI to detect tumor response to therapy. And finally, amino acid PET is recommended by the Response Assessment in Neuro-Oncology Working Group in addition to MRI. Finally, I would like to acknowledge the work of many colleagues who have contributed to our research in brain tumor imaging in the last decade. These are the Brain Tumor Group, the PET Group, the MR Group, and the Department of Nuclear Chemistry of the Research Center Jülich, and the clinical colleagues from the surrounding university clinics in Aachen, Bonn, Düsseldorf, Cologne, and Frankfurt. This brings me to the end of this webinar. Thank you for your attention. If you have questions about the webinar, please feel free to contact me at my business email address as indicated at the bottom of this slide. Goodbye.